foods. I used to tell them their calories. I used to tell them their, like, how many calories were in the foods. I just had no idea what I was doing because there also wasn't a lot of training because this unit was just so new. And there was, like I said, only one dietitian on it. So I did just get kind of thrown in. So I would say really learning how to set a boundary with the patient, understand what their eating disorder is versus what they are was really a big difference for me. I think initially you think it's like all in one and the same, like this is just a person, and then learning that like an eating disorder is its own entity.
Welcome to the RD Roadmap, Journey to Eating Disorder Expertise. This is episode 12, The 14ers, Understanding Higher Level of Care and Beyond, Inpatient, with interview guest Meghan Foley. My name is Jill Sakey, registered dietitian.
My name is Mateos, registered dietitian.
All right, welcome. This is Meghan Foley, who works as the clinical nutrition manager at ACUTE at Denver Health. And so excited to have you and talk with you a little bit about your experience at this level of care. So we're going to dive right into it a little bit. And I think my first question for you will probably allow people to know a little bit about you and kind of how you evolved to this position. So how did you get to ACUTE and, into the position you are now? Clearly lots of experience to become the clinical nutrition manager, but yeah, how did you get to ACUTE?
It was a series of fortunate events, I would say. I moved out to Colorado and I got a job at Denver Health, which is the big house of ACUTE or a subset of Denver Health. And so I got a job just covering a maternity leave and doing general medicine. Really excited when I took the job because the woman going out on maternity leave actually covered the eating disorder unit.
Oh.
I would get to do that. Very naively thought that I would get to do that. And they else into her role and I took more of the general floors and was a little bummed. And then several months later, they had an expansion on the unit. They used to only be a 4-bed unit and they expanded to 10 beds. And so they needed a full-time dietitian. And just because they already knew me, they gave me this position just as a regular dietitian on ACUTE. There was really no leadership team or anything like that. It was very, very small. And I was just able to kind of stick it out and kind of climb through just the expansion. So I think a lot of it was luck in the sense of I was one of 2 people who worked there. And then as we continued to expand, they just needed more and more dietitians. And so I started out as a lead and then I went into a supervisor role. And then that ended up hiring a bunch of nutrition technicians along with dietitians. And so now we're a team of, I want to say 15 or 16 people between dietitians and nutrition techs. And so they obviously needed someone to be in charge of such a big team. So I think my experience, but also kind of my seniority and longevity on the unit kind of helped mold me into this candidate. But I'm really lucky to have it. I love doing it. I love my team. The dietitians here are amazing. The techs work so hard. So I feel really good about it.
Wow. So how many years now have you been at ACUTE?
I have been at ACUTE for about 10.5 years.
Wow. That's amazing.
A long time. Yeah. So I've seen it grow from, like I said, a 10-bed unit, and now we're a 30-bed unit. So it's kind of been steps along the way. So it's been really cool to see it expand so much and be able to treat so many more patients that need us.
That's amazing. Well, thank you for your history and all that. So you started really as a clinical dietitian right out of school in the hospital setting and kind of got that, like you said, it was a series of good and fortunate events that led you to ACUTE. So that's amazing. I feel like that's a little bit how my career went into the eating disorder field, like just jumping into there without knowing what I was doing.
Yes.
So on that note, what would you say your biggest learning curves were? Because that's, I'm assuming you didn't I didn't have a lot of training in undergraduate or graduate school. So yeah. What are your thoughts?
Yeah, it was a huge shift. So I actually started doing community nutrition at WIC, was my very first job out of college. And so I got some counseling experience through that. And then of course, coming into the hospital setting, I got all of my clinical experience. So I had like a lot of the MNT for clinical stuff and then the counseling, but I had no idea what to do with eating disorders. I would say more specifically like setting boundaries with patients. And so I will admit that the first year or so I worked here, my sessions would be sometimes like 90 minutes long with patients. There was no like stopping. So like there was a lot of back and forth. I did get talked into some things probably from patients. I used to tell them their calories. I used to tell them their like how many calories were in the foods. I just had no idea what I was doing because there also wasn't a lot of training because this unit was just so new. And there was, like I said, only one dietitian on it. So I did just get kind of thrown in. So I would say really learning how to set a boundary with the patient, understand what their eating disorder is versus what they are was really a big difference for me. I think initially you think it's like all in one and the same, like this is just a person. And then learning that like an eating disorder is its own entity helped me move forward and progress more and be able to set like compassionate boundaries with my patients to help them make progress. And I just have noticed along the way, like it just has allowed my patients to be more prepared for the next level of care, to do better with their team, to be able to open up more and trust you more, because I do think they know when they're maybe pulling one over on their dietitian and it makes them not as confident in their providers when that happens. So even though it can be hard on them, I do think ultimately it helps them in the long run.
Oh, it's amazing. What I know, Matthias, that's y'all have a little bit of a career similarity there.
Yeah. I started with clinical, then I went to community. I worked for WIC as well for a number of years. Then, and I'd never stopped to really think about the fact that I learned a lot about counseling at WIC too.
Mm-hmm.
So that's interesting.
Yeah.
Sure. That's amazing. So I always think, what is the term? Learning by fire, or what is that? That's what it feels like you learned with.
Yes.
That's a little bit of what I did too. So I'm
Yeah.
sitting here going, yep, I remember that. So
Sounds familiar.
what was I thinking or whatever?
Yes.
So. Awesome. Okay. So how would you best describe the difference between inpatient and residential? We did an earlier podcast on just the different levels of care and just very superficial overview. So we were hoping to dig deep with someone who actually has had for you, a long career in this level of care.
Yeah.
So, it sounds like you haven't worked in residential level of care, but, and I think a lot of people know there's some difference to it, but what would you describe it as?
Yeah, I can do my best because, like you said, I have never worked in a residential level of care. And I will also say acute considers itself like a medical stabilization unit. So it's even a little bit different in the sense that, from my understanding, at least, our kind of team is led by a medical doctor versus I think in inpatient and residential, it's more of a psychiatrist. So here we're really focused on the medical complications that can arise from severe malnutrition. And I think that's been something that's been kind of cool that's come up over the last few years. We've changed from the Acute Center for Eating Disorders to the Acute Center for Eating Disorders and Severe Malnutrition, and understanding that regardless of the cause of the malnutrition, the medical complications are quite similar. So whether you're severely malnourished because you restrict your nutrition or because you have an underlying medical disease or you have cancer, the treatment is going to be the same from a medical standpoint, obviously a bit different from the behavioral standpoint. So I would say kind of one thing, we are in a hospital base, they all have their own rooms with a hospital bed. The beds are different. Just because they have no subcutaneous tissue. And so they're kind of like bones laying down. So our beds are different to kind of help prevent skin breakdown. They all are on telemetry when they first get here. So we can monitor their heart rates when they're going through refeeding syndrome. They often struggle with like even getting up and getting out of bed. Their heart rate will go really high. Working with physical therapy, it can go really high. So, and then when they're sleeping, it can get really low. So monitoring their heart rates for safety is another thing we can do here. Of course, we can put them on IVs if we need to. They have a one-to-one nursing assistant. So if they're not able to ambulate or move, they have someone in their rooms at all times to help them use the bedpan or turn. I had a woman recently who, in flight to come to the hospital, ended up losing her airway and was intubated and was in the ICU for 6 weeks, got a stage 4 pressure injury. And so we needed wound care available for a significant period of time to make sure that her wound was closing up appropriately. We can do parenteral nutrition. That's another thing that I know is very different from residential, is just we can do nutrition through their veins if they need it. Of course, as a dietitian, we try to avoid it unless they absolutely need it, but it's an option that we have. Another thing is we can do surgical feeding tubes, which I know there's not many residential treatment centers that will take a surgical feeding tube. So if they have a G tube or a GJ tube, we can handle that as well. And then we also have like ICU access. And so if we had a patient come in on Friday and her electrolytes were really out of whack, so we sent her to the ICU for a couple of days. We can also have anybody come over and consult. So we have endocrine who can come over for our diabetic patients, or cardiology can come over if there's any sort of like heart rate things going on. So we have access to a lot of specialties to help with like how severe their malnutrition can be and like what those complications can arise.
I just think of a lot of that medical severity and ability to kind of attend to it 24/7.
Yeah, exactly.
Residential.
Yeah.
Matthias, did you have any thoughts there, questions? You have that look on your face of like, you probably have 1,000.
I'm just imagining like it sounds really interesting. And I'm imagining how it is to navigate, having so many having access to so many resources, so many providers, how powerful that must be, and how important it is too that people are informed of eating disorders, because I that's the part that makes me, there's not a lot out there, and people can do a lot of harm without thinking that they're doing something helpful, so I was just like fascinated listening to all the different things that you guys have available.
It's really amazing because I do think it gives the clinicians a lot of confidence too. Like as I'm treating someone inpatient and I know they're going through refeeding, I don't have to like slowly feed them or worry really too much about what's going on because I know there's a medical doctor monitoring all their electrolytes and repleting them if something starts to drop. Whereas if I were like in an outpatient setting or even residential where they're not being monitored as closely, I can imagine there's like a little bit more caution that comes with that. And I think you really hit the nail on the head. Having specialists who work on our unit who fully understand like the complexity of eating disorders from a mental health standpoint and a medical standpoint is so special and unique. And though even though our like consultants don't necessarily understand it, they have immediate access to a doctor who understands it. And so they can work really closely together to make sure the patient is treated comprehensively. So you are right. We're very spoiled here to have access to all of these people for sure.
I was fortunate to have clinical experience in my early career. And I know, Matthias, you have an RD degree essentially from Brazil. And that's an intensity that's so different than how I was trained. I know, and we've talked about that in previous podcasts, but I feel like that's helped a lot, just kind of knowing on an outpatient basis, there is some medical complications that can happen. But to your point, I have that gut wrenching feeling when I have someone that isn't willing to go to higher level of care. And, sometimes it's a little bit more obvious when they need maybe the level of care of inpatient. But a couple of times I know I've been in practice for a while that, in Houston, let's say I sent them to the ER at Texas Children's and they were admitted. And, the mom, I remember, sent me a picture of the telemetry and her heart rate was 28. I'm like, oh my gosh, that feels very uncomfortable and unnerving. So anyway, so I just think, a lot of times people come into the field, not even having clinical nutrition experience at all on a, unit, not even acute, but just in a hospital setting, which I think can be a challenge in eating disorders for sure.
Yeah.
So, okay. So I know acute, and we have some other more detailed questions to go through. I know acute is also a research unit, and I was just hoping you could talk a little bit more about that. And then how are you involved? I know you've written a chapter with Dr. Mehler in his 4th edition of his book. So would love to know kind of how you've been involved with that. And it sounds like a lot of the protocols of acute, were probably in coordination with him as a dietitian working side by side with him.
Yeah, Dr. Mehler is a big advocate for dietitians. He really understands the importance and really promotes the importance of a dietitian in an eating disorder unit. So he gives us any access we want to and sort of like research. He'll help us out in whatever capacity he can, and he'll bring up a lot of ideas too. So acute is definitely a big research unit. There's been so many articles and publications that have come out throughout my time here. I think that generally what can instigate it is we'll see like a unique problem, and then we'll go dive a little bit deeper into like why that happened and what the outcome was. So sometimes it's just the patient, like I had a patient with kidney disease and she needed to be on dialysis. And so it was really talking about kind of her electrolyte abnormalities and her renal function, and writing a whole paper just on this like one case study about this patient and understanding like why her kidneys got so screwed up, I guess, throughout her process of malnutrition and laxative abuse. And so it's bringing to light the correlation, I think, of behaviors patients are using and how it can affect them physically. Whereas I think in a ER where a patient might go in where they, you know, are extremely dehydrated or their electrolytes are really low, oftentimes the doctor will just give them a bag of fluids and then send them on their way. And then they might develop pseudobarter syndrome because of that. And so I think it is trying to provide education to the world about having a better understanding of eating disorders and what medical things can arise. So as you mentioned, you know, Dr. Mehler was really generous and offered me the opportunity to co-author a chapter in his book with him about nutritional rehabilitation. And so that was a really great experience. The dietitians just are submitting for a publication right now on analyzing older populations and their nutrient needs when they're refeeding. So we did a whole study on that, and we're really lucky that we have really good access to a big patient population. So I think we started with 600 patients in that study and it went down to around 400, but we can pull so much data from our own patient population over so many years since we've gotten what we call our electronic medical records. And so since 2016 now we can just like retroactively pull all of this patient information. So we have a lot of access, and I think it's just important research because it's really the only place that I'm aware of, at least, that can do this kind of research, because we're really the only place that treat patients that are so extremely malnourished. Like, it's not uncommon for us to have a patient who's 50% of their ideal body weight and treat them for, 10 weeks. And so we have a lot of access to their history, their charts, getting to know them. We have a research specialist on the floor. And so she identifies patients that are appropriate for research studies that are actively going on. And like I said, to kind of answer the second half of that question is, our involvement or my involvement can be as little or as much as I want. So kind of ebbs and flows. But it's really wonderful to have the opportunity to be involved in kind of groundbreaking research that can be utilized for clinicians, all over the world.
I just always think about, research studies, and you want your, the number of people that are in it to be more than 10 or 12, so
Right.
having 400 is really amazing, and
Yeah.
really gives some legitimacy to the research that comes out. I just the conferences I've been to, in particular, Eating Recovery Center and multiple ones, a little bit more online, Dr. Mehler, just hearing some of the research, it feels really, it's a confidence feeling of like, okay, this isn't just guesswork. This is definitely something that's, you've seen in clinical experience. So
yeah.
And I think it sounds really fascinating too, because there's a tendency of dismissing, my experience at least, is that there's a tendency of dismissing the impact of malnutrition in so many medical problems that arise. And people oftentimes are, have 10 specialists that they get sent to, and nobody's seeing that the malnutrition is like the birth of a lot of the problems happening. You guys have an opportunity to look at it from that perspective, like how is malnutrition impacting the renal problems that this person is experiencing, and I got goosebumps.
Yeah. But what's so amazing about it is a dietitian specifically is recognizing that nutrition is pretty much the best thing they can do to like fix a lot of these problems. We'll have patients who have been into acute, 10 plus times, who we keep thinking like this is the time they're going to end up on dialysis. And then we just give them enough nutrition and hydration, and all of a sudden their kidney function improves dramatically. And so I just love that so much about being a dietitian and working in this patient population, is being able to like definitively say, if we nourish you, most of these problems will resolve. And so I just have always thought that's so cool.
Yeah, that's wow. I know you don't think about that sometimes. Where
Mhm.
I just the word that comes to my mind is hope. There's
Yeah.
still a lot of hope, especially. So that's amazing.
So, as a younger clinician in the field, less experience, even in the outpatient, I've seen some challenges, and I wanted to hear your perspective because one of the things that was really mind-boggling and fascinating to me was the rigidity that some of our clients would come in, and having to navigate all of that. How how has it been how experience has been, navigating care for a brain that oftentimes is very depleted? How has that
Mhm.
been for you?
Yeah, it's really tough. I mean, it's obviously gotten easier with experience and just fully understanding that it's not personal when they don't do what you ask them to do or they don't take your recommendations. It is part of their illness and their disease. I think one big thing is having a comprehensive care team. I'm not the person on their team. I am a person on their team. And so being able to work cohesively with their psychologist. So here at Acute, we see our patients 5 days a week. And then their psychologist usually sees them 3 to 4 days a week. Additionally, we'll have like meetings with the whole team and the patient. And so we get to know them really well. So I think that's really, really helpful. I will sometimes have a patient here, like I said, for 8 to 10 weeks. I'm seeing them 5 times a week. It's just a lot of time spent with their care team. And so I think the more they can trust you and build rapport and understand that you're there to support them, that can be helpful. Additionally, doing co-treatments with the psychologist can sometimes be really helpful. Kind of if they have a better relationship with their psychologist and I'm asking them the same question, I get nothing. Their psychologist might ask it in a different way, or they might just trust their psychologist more. They might open up a little bit more and then I can work with them. The more I think we can understand like what their goals are and then navigating that together, I think is another helpful thing. But I still to this day have to work on that kind of inter inner feeling of like frustration sometimes where I'm like, just take a bite of the bread, like just one bite of the bread, because sometimes it definitely feels like a power struggle of like, I said I'm not going to eat the bread, so I'm not going to eat the bread, just eat one bite of the bread. And so understanding kind of the give and the take, I think is important too. And I would say maybe kind of luckily for me is it's also not my primary goal. Like I'm not here to do the behavioral piece as much. I'm here to do more of the medical piece. And so we give them a lot of education on that of like, we have to start with these things here so that when you get to the next level of care, you're not feeling so overwhelmed. I think that we have definitely fallen victim of to being just like, we just need to nourish you and move you on. And then they show up and they're like, what is this? I don't understand how to do any of these things. I'm leaving. And so we have worked a lot in the last handful of years of really kind of having stepping stones towards making them feel successful when they go somewhere less intensive than not being prepared at all. I wish I had a magic answer of how to deal with the rigidity because it can be really tough. And I think that I find this so fascinating how it's associated with like often associated with their type of eating disorder. Like we can kind of identify almost like when you walk into a patient's room if they are a restrictor or if they have binge purge subtype, because a restrictor's room is very organized and neat and everything's put in its place and they have very specific handwriting. And then when you go into a binge purge room, there's stuff everywhere and it's a little bit more chaotic and sporadic. And so I think we notice the rigidity a lot more with our restrictive subtype eating disorders than with the binge purge subtype.
I think that's such good advice though, because being able to sit and think it's not really about me, it's a part of their because it can get we can get in our heads a little bit of like, am
Mhm.
I just not super effective as a
Mhm.
clinician? So
Yeah.
really good advice. Um, was it scary, starting to work with very medically compromised patients?
Yeah, I don't know if scary is the word I would use. Overwhelming for sure. Like I have always felt super safe in my practice because I'm in a hospital. So I kind of have always been able to know no matter what, there's someone else above me who can deal with this. So like one thing that comes to mind is allergies. Like if we're testing an allergy, I know somebody can be bedside with an EpiPen within 30 seconds if they need to. If a patient becomes unresponsive, I know I can hit the call button in an emergency and 10 people will run into the room. So I've always felt really confident in the fact that there's always someone more knowledgeable or more appropriate than me to care for the patient in medical settings. But I would say, you know, every time I think I've seen something really serious or sick, and I'm like, okay, I've really seen it all now, like something else really scary happens. Like we had a patient who came in, she wasn't like more malnourished than like our average patient, but I think what really scared me was the fact that she ended up getting pancreatitis and she ended up passing away because there was just no way for her body to heal itself. It was so ill from her eating disorder that like a medical complication that most people would be able to deal with came up for her and she couldn't fight it. And so I think that's what scares me about this patient population sometimes is they often think they're invincible and they come in right before they're about to die because they start to feel like they're about to die. And then after a couple of weeks of nutrition, they're like, I feel so much better. I'm totally fine. I should be able to go home now. And so I think it's fascinating that our bodies can bounce back so quickly, but it's very scary how their brains can't understand like your body can only go through this so many times, or you're at such higher risk for death because you have no nutritional reserves to help support you through a traumatic event outside of your malnutrition. So that part is always going to be something I don't fully understand is kind of their
Invincibility.
inability to fully comprehend how ill they are, I guess.
Mm-hmm.
Think of that multi-organ failure concept. You know, they're coming in probably with, you know, one organ probably starting to fail. And then, like you said, something else kind of pops in and
yeah,
they brought it, you know, I've just seen even in an outpatient basis, you still have the conversations. I just had this one with a client that, you know, was very, very ill. And she ended up having a resection of her colon and she just lost probably 20 pounds. And so she has 20 pounds to restore from, and she was pretty stable for a while. And I was telling her just the other day, I'm like, if you go through another incident like this where you are now, just think where you're going to be. And so just getting her to restore again because she feels fine. You know, it's the same confidence. I feel fine. I feel great. I like my body where it is now. And I'm like, oh gosh. So anyway, totally relate.
Yeah.
Yeah. Thank you for that answer. What are some I think that you answered this next question a little bit throughout the interview already, but what are some pros and cons of working at this level of care?
I trust that you guys will take out the things that aren't appropriate that I said.
Absolutely.
I would say, I mean, the pros is number one for me is the relationships I get to develop with my patients. I think, often dietitians get a really bad rap in eating disorder treatment, and everyone always says like the most hated people on the team. And that might be true, but more often than not, in my experience, I have pretty good relationships with my patients because I see them more than anybody else on their team. Their doctors come on every 5 to 7 days, and then they go off for 5 to 7 days, and a new doctor comes on. And like I said, their psychologist sees them 3 or 4 times a week, but their dietitian is their consistent every single day of the work week that they see. And so really getting to build rapport, especially when they've been here for a while and you don't have to, the sessions aren't quite as challenging as they are initially, really getting to know more about their personal lives so we can bring that up into like reasons why they need to remain motivated and what they're working towards. And so I really love that. Like I just got an email from a patient 2 days ago where he was telling me about how well he's doing, and he was here like several months ago. And so kind of those check-ins and saying like, wow, I really was able to support this patient and like see a positive outcome. I love that part. As a dietitian, I also really love that I've said this 1,000 times and I'm sure I'll say it 1,000 more, but the merriment of like clinical nutrition as well as like a counseling or nutrition education piece, I really enjoy that. I feel like you generally get one or the other as a dietitian. You're either doing outpatient, you're doing a lot more counseling, or you're doing clinical and you're maybe doing ICU. But this is kind of the best of both worlds. I get to see extremely ill patients. I get to use all of the things I learned. I get to do TPNs, I get to do tube feeds, you know, I get to look at different disease states, and I get to really talk to these patients to provide them education about why we're doing these things. So I love that so much. And then getting to see their progress is another really, really amazing thing. Like I said, we're seeing patients sometimes at 50 or 40% of their ideal body weight. They might not be able to walk or lift their head up when they get here. And then to see them be able to walk out of here, you know, is really, really cool. To be able to look and see, oh my gosh, they gained 30 pounds in the time that I've known this person. They might not love that, but I think it's really great. So those are definitely some pros. Cons, I would say, this is just my own theory, but patients who are able to get this ill, a very unique subset. You know, there's so many people in the world with eating disorders, but it feels like such a unique subset of patients who are able to allow their bodies to get to such a dramatically ill and low body weight. And those brains, I think, are just more determined and sometimes a little bit more stubborn. And so if they don't want to do something, like, they're not going to do it most of the time. And so they might follow the program while they're here, and then they might say they're going to go somewhere and not show up, and then show up 6 months later in the exact same space. And that has been a huge challenge for me, is kind of seeing these patients come in over and over and over again, because you don't know, like I said, when their last chance is going to be. And understanding, though, like, it's not a choice, right? Like, this is a very serious mental illness. Like, I fully understand that they're not choosing to make themselves this ill. And it can be challenging sometimes to just kind of want to shake them and be like, oh, just follow the program. You know, you'll get there eventually. There's evidence to show, but they won't take all of the steps. We just have so many patients who stop after acute, even though we'll tell them to go to residential or inpatient. We'll set them up for that and they just won't show up. And so that can be a really challenging part, I would say, of this. And then the patients that we see pass away, you know, like, it's pretty rare that it happens at Denver Health. It's probably only happened to a couple of patients who have actually passed away, like, in our hospital from their eating disorder, but it'll be patients who discharge and didn't follow a recommendation, and then we hear that they passed away. And so that can be really tough too, because they are really, really sick.
Yeah, I can imagine. The last two questions stem from my curiosity. So the first one is, could you describe a day in the life of a dietitian that works at Acute? And the last question would be, what advice do you have for new clinicians entering the field?
Sure. Yeah. So for dietitians who work at Acute, we come in, of course, every day, and we start with signing up for our schedule. So we have a scheduling board where we can kind of identify what our day is going to look like with our patients. And then we do pretty good chart reviews every day. So we read through all of their chart notes from either the day before or the weekend, depending on what day of the week it is, and kind of see if they've been completing their meal plan, if they've been using any sort of behaviors, if they're connecting to their tube feed, or maybe dumping their tube feed out, or if they're purging, or whatever it may be, to kind of really identify what our session needs to be about that day. So we'll meet with the patient for about 30 minutes. And our primary goal is to help them with menu planning. So picking out their meals just for usually 1 to 2 days at a time, which I recognize is a lot of attention for the patient. But if you keep in mind that they're coming in at such a low body weight, sometimes it's really all they can handle. They can't even get through 1 day sometimes because it's so overwhelming and stressful for them. And so we try to take our time with them and guide them through the menu planning process, while, like I said earlier, setting appropriate boundaries of, like, this is the time we have today. You know, this is enough time to do these things. So it can require a lot of redirection of not going back to certain subjects or certain parts of the menu, and then really addressing any things that are coming up. So if they're struggling with their body image, or, like I said, they're struggling with behaviors, kind of addressing that either one-on-one with the patient or with the team and the patient, to make sure that they're able to continue to make progress. We do have pretty strict self-inflicted weight gain goals for our patients. And so kind of really making sure we're supporting them and moving through that every week is a big piece of our day-to-day. And then we're also really lucky, like I said, that we have a big multidisciplinary team. And so a couple times a week, we have 90-minute meetings with the entire multidisciplinary team where we talk about every patient on the unit from every single discipline's perspective to really see how we can continue to work together to support the patient. And then additionally, other things are going to come up. For instance, if we have an adolescent on the unit, because we take ages 15 and up, we will do weekly family meetings with the adolescent's parents and see how we can support the adolescent, whether it's with school or with, their meal plan, because we follow the idea that if we have an adolescent, like the dietitian's in charge of their menus, so how we can support them with that. And then just really anything that comes up during the day. There's a lot of talking with the nursing staff and adjusting tube feeds, and checking in with the doctors and seeing if we need to be adjusting their meal plan because of something that's coming up medically. So that's probably kind of like a very high overview of what we do day to day. And then as far as advice for new clinicians, I say this every time I hire a new employee, my number one thing is just like ask questions. You can know eating disorders and you can know clinical nutrition, but you don't know, necessarily working at acute. You don't know the medical complexity of what you're doing. Just like if I were to work in a residential treatment center, I wouldn't know what I'm doing because I've never worked in a residential treatment center. And so I think not being afraid to just ask questions about things you don't know is really, really important. There's such a huge learning curve, at least in my experience in working with an eating disorder patient population, because like Jill mentioned, we don't get this in our undergraduate degree programs. If you do, it's like a very small class on it or even just a couple of hours. And so I think asking questions is really important. And the other thing is doing the best you can to work with like a multidisciplinary team just brings so much more insight into what the patient is going through because everybody's seeing a different side of the patient. I'm usually seeing a pretty behavioral, sometimes angry side, whereas a psychologist is maybe seeing a more vulnerable side, and the doctor might be seeing a side where the patient's just saying what they think the doctor wants to hear. And so really being able to come together and work together to support the patient, I think is also extremely helpful.
We talked about earlier in another podcast, the Dunning-Kruger effect. Not sure if you've heard that concept a little bit, but it's essentially two researchers kind of looked at the essence of individuals coming into a situation where they think they know a lot more than they think. And just the, kind of how do you prevent that? I'm the expert. And then diving down to the pit of, I don't know what the hell I'm doing to kind of coming up to, okay, I'm confident, and I think what we've talked about is like, know what you don't know, and so if, even if you've been in the field for a while, and I think, we'll have some people that have, and others that are just coming in as a new career, the asking questions part is, invaluable. You have to do that. And I think on different levels of care, yours, you have a lot of support and clinicians that are, there to support, that perspective. Outpatients always a little more difficult coordinating care and trying to find a time to meet with the team because they don't get paid for that time, or they don't have time, they're seeing XYZ clients. So I think there's a lot of nuances in each level of care for sure.
For sure.
Yeah, you got to know what you don't know and ask questions. So
I agree.
Jess, any other thoughts on your end?
This was fascinating. I really appreciate all the knowledge that you shared, all the experience that you share. It sounds very interesting to do what you do, and I was a lot more into the clinical side before, working with WIC a little bit, and then switching over to eating disorders, and I've never seen that combination, that intersection.
Yeah, well, I'm happy to share. I know it can be hard to find different levels of care and different specialties. So I'm happy to share, and I appreciate you guys having me on.
Thank you so much, Megan. I appreciate your time and expertise for sure. We'll see you soon.
Yeah, thank you. All right, bye-bye.
Bye-bye.